From Diamond Pharmacy and Optics, this is PodcastRx with Chris Bender. When he's not on the mic, Chris is a clinical pharmacist with the Office of Pharmacy Therapeutics and Integrated Clinical Services, or Optics. He routinely helps providers in correctional and long-term care facilities make better medication decisions to improve patient care. And we're so happy that he's sharing his expertise with you.
Hoping that today can be a real knowledge booster.
A classic Batman and Robin or Jordan and Pippin type scenario.
A full armamentarium of options that clinicians can choose from.
When it comes to managing hypertension and reducing adverse cardiovascular events, what is the ideal blood pressure figure that clinicians should target? Optics pharmacist Henry So joins Chris for some back and forth around this question. They look at the evolution and proliferation of blood pressure guidelines, examine controversies around certain studies, share some of their own personal experiences with hypertension, and ultimately discuss whether they think a lower number is necessarily better. Before that, Chris shares some quick drug approval and guideline updates. And afterwards, we end things with a look back at how the death of a U.S. president 80 years ago sounded the alarm on the dangers of untreated hypertension. I'm Adam Campbell, and thank you for listening to PodcastRx with Chris Bender.
Well, hello, Chris. How was that NCCHC experience last month? Did you get more than 2 people to attend your presentation this time?
Yes, mission accomplished. So
Good.
This year, I think I got want to say around 25 people. It was a very nice little intimate group. The room was kind of fit perfectly for that amount of people. So it felt good. I feel like everyone got a lot out of it. I had a lot of good questions. And everyone stayed engaged the entire time. The thing that I noticed that was kind of funny, though, that I didn't consider was that when you do a presentation on weight loss that's so applicable to everybody, at least to some extent, and something that everyone sees on social media, I wasn't prepared for all the questions of random things that people had seen online, on TikTok and stuff like that. So I was getting questions like, what are your thoughts on this particular type of vitamin injection? And my perspective, I was coming into it I had prepared using guideline information, evidence-based information. I didn't necessarily peruse social media for it. So I got caught blindsided with a couple questions like that. But for the most part, I think everyone kind of got a lot out of it. So it was a great experience.
Great. I'm glad to hear it. And that sounds like that could inform your next presentation, ancillary to that topic.
Yeah, exactly.
And kind of like the vitamins one that you did a year or 2 prior at NCCHC, where you were addressing those myths and
vitamins and supplements.
Yeah.
Trying to dispel some different things and giving actual credence to the scenarios where they do in fact work. But I mean, a lot of that presentation was kind of a lot more debunking than anything. So yeah, kind of falls right in hand with that one. Yeah.
Well, for anyone listening who not aware of what we're talking about, last episode for March, we were talking about Chris's upcoming presentation. It was coming up for the NCCHC conference in early April in Louisville, Kentucky. Chris gave a presentation on overweight and obesity management in the corrections environment. And that episode actually took the place of something we were going to talk about earlier. We had a planned episode for February that I had to back out of. And it was originally to talk about heart-related topics. It was American Heart Month in February, of course, and we were going to center that discussion about blood pressure, hypertension, and the ideal blood pressure target number. And as we're going to find out in our main discussion today, there's some difference of opinion on what that number, that ideal number is, different avenues of research and things, putting out different numbers. We're going to talk about that. And to get more perspective on this issue, I thought it was a good time to finally get a guest on the show to bring in some further insights. So I will say that it brings my heart, see what I did there, much joy to welcome our first guest to the show, this iteration of the show for discussion. Well, he's been on the PodcastRx show many times. You know him, but he hasn't been on this current iteration with Chris. So please welcome back from Optics, Henry So, to the podcast. Hi, Henry.
Hey, I was waiting for an applause button that you would play or something like that, but
I'll work on that for next time.
Cue fanfare.
finally invited back on, but I'm so happy to be here, especially with Chris and you guys. So thanks for having me back.
Absolutely. It's always good to have you. What's new since the last time we listeners heard from you?
So I guess since the last time I was on your show with a podcast, the only notable things that's really been going on with me was I just did, I believe, 2 more NCCHC presentations, navigating through high-cost diabetic drug therapies in special populations. And then subsequently in the next season, I did managing the pressures of ambulatory care or within a virtual ambulatory care module, where we manage a lot of different disease states such as diabetes, HIV, and most relevantly, hypertension. So that's really been pretty much what's going on with me.
Well, you're always a busy guy, and we have nothing but gratitude for you taking time to come on today. So thanks again, and looking forward to hearing from you and getting into this discussion on blood pressure and hypertension and in just a bit. But first, we need to take a closer look at the most pertinent medication news affecting institutional healthcare providers. So let's go into the clinic.
All right, let's do it. So in drug approval news, we have a new class of antibiotic on the market, the triazase naphthalene bacterial type 2 topoisomerase inhibitors. This is perhaps the last time I'm ever going to say that class name out loud. We have gepotidacin to be sold under the brand name Blujepa, and it was approved to treat uncomplicated UTIs in females 12 years and older after it showed superiority over nitrofurantoin, which is a commonly used first-line treatment option. Now, this indication, not to be too nihilist here, but the indication doesn't necessarily move the needle for me right now, as UTI is often successfully treated with less costly agents. However, what is interesting to me is that gepotidacin has shown efficacy, at least in the lab setting, against some resistant subtypes of E. coli, namely ESBL, for which there are currently limited oral options. So this, of course, is going to require further studies in humans, but it may be a future niche for this agent to fill. It's a common strategy of antibiotics. It's like get to the market for something simple and then, let the market sort it out as it becomes used off-label for other indications. Now, in terms of guideline updates, the ACC and AHA released an updated guideline on the management of acute coronary syndrome. In the guideline, they recommend at least 12 months of dual antiplatelet therapy, known as DAPT, with aspirin and a P2Y12 inhibitor, with ticagrelor and prasugrel being preferred over clopidogrel in those with a low bleeding risk. Now, for those with a high bleeding risk, however, providers could consider transitioning to a single antiplatelet therapy, that being either aspirin or a P2Y12 inhibitor, after at least 1 month of DAPT after the individual underwent percutaneous coronary intervention. And additionally, those individuals who are on an oral anticoagulant, such as those individuals with the underlying AFib diagnosis, they're actually going to receive triple therapy. So they're going to be on that DAPT plus their anticoagulant, but only for 1 to 4 weeks, at which point aspirin should be discontinued. And then for these individuals, clopidogrel is preferred as the P2Y12 inhibitor because it has a lower bleeding risk than the other 2 agents. And then let's just run through a few quick hits. There's been speculation going on about GLP-1 agonists and the risk for suicide, where a recent study actually suggests there is no increased risk. So this is a growing area of research, so there's likely going to be more information to come, but this is obviously some positive news for these medications. Now, sticking with the GLP-1 agonists, a recent economic evaluation has suggested that, at least when it's used for weight loss, semaglutide and tirzepatide are not cost-effective, despite their robust clinical outcomes, as we all well know, at their current set prices. They estimated in this assessment that to be considered cost-effective, the prices of tirzepatide and semaglutide would need to actually be about 30 and 82% lower, respectively. And finally, there has actually been some concern. This was a concern raised last year regarding the presence of benzene, which is a known carcinogen, in the acne product benzoyl peroxide. Well, a recent FDA investigation of 95 products showed that less than 10% of them contained significant levels of benzene, so the overall risk is relatively small. However, as a precautionary measure, the American Academy of Dermatology actually now recommends storing benzoyl peroxide products at room temperature or below, and to discard those products that are either expired or exposed to heat.
Everyone knows that pharmacists dispense medication, but the clinical pharmacists in Diamond Pharmacy's optics team dispense more potent resources: information and education. The optics pharmacists are frontline medication experts for Diamond's many institutional partners. Whether you work as a provider in corrections or long-term care, the optics team is standing by to answer your on-demand medication questions. But optics is far more than a drug information hotline. They also create proactive knowledge resources like webinars and this podcast to keep partners up to speed with the latest drug developments. And they help providers to better manage costs and therapeutic outcomes with their in-house medication surveillance monitoring program. Learn more about the optics team by going to diamondpharmacy.com and clicking the clinical support tab. See pharmacy care more clearly with optics. Let's get back to PodcastRx.
All right. So, Chris, in planning for this month's episode, I mentioned wanting to get a guest on the show for the first time, at least since you've been the face of the show, but also to get a topic that could generate some debate, or at the very least, just some spirited back and forth. And you brought up blood pressure treatment goals as a possibility. You were concerned this might be too bland, but I thought, Chris Bender, he doesn't do bland anything. And so we arrived on this topic of hypertension, blood pressure goals. And of course, it was natural to get Henry as our guest on here. And Henry, I know you edited, or I edited for you, a hypertension webinar that you had worked on within the last couple of months. So I assume you're still thinking about this a lot, correct?
Yeah, of course. I mean, blood pressure is always on my mind. It's something that, for lack of better words, circulates within my history. Nice. Yeah. My history, my present, my future. I mean, everyone out there who's listening, I am so sure that there's someone that must have experienced some sort of life-changing event or any kind of life-changing communication from one of your providers, physicians, whomever, that basically is like, hey, blood pressure is too high, or the consequence of XYZ event is because of your blood pressure. I mean, I try not to get too crazy with it, but ever since my days of blood pressure clinics as a pharmacy student, I usually will whip it out, my automated blood pressure cuff, that is, whenever I visit my family or whenever I have a lot of friends over. And it's not really a cool party trick, but it is a very eye-opening experience for a lot of different people and a lot of my friends my age or different family members who are kind of getting up there in age when they see how elevated their blood pressure is. So yeah, it's always on my mind.
It's nice to have, and it's nice to have one of those around too, Henry. I mean, I don't use mine probably as much as you do, and I'm not as prone to whipping it out at parties, but I can say I have used it, I have used it for my family and stuff when they've been over at the house and whatnot, and actually had a moment with my dad where it kind of clued us in as to a better way to adjust his blood pressure medications. Yeah. So it's handy just like having it around. So not an ad, but it's nice. I'm an advocate for having a home blood pressure monitor. Well,
yeah. And I think the big thing that I like to explain, at least in layman terms, is that, yeah, whenever your blood pressure is elevated, whenever it's extremely high, you want to think about your blood pressure as kind of like whitewater rafting inside of there. And it's just every crash, every wave, every turbulent water that crashes against the inner lining of your blood vessel or your endothelium, that can and sometimes will cause little damage points or little breaks or little cuts that eventually will initiate this atherosclerotic process that kind of gives people the idea of, blood pressure is high. What's the big deal? Well, it has a lot to do with the damage that it's doing within you. So, that's why I always carry it around me. Sometimes I get stressed at work, or sometimes I get a little stressed at home, maybe playing some video games or something, and check my blood pressure and try to use that. What is it, Chris? Do you know that 4-8-7 rule or 4-7-8 rule where you inhale 4 seconds, hold for 8,
box,
and then exhale?
Box breathing.
Yeah, I try to employ that a lot, and I really do see a lot of significant reductions when I finally just take a breath to calm down, especially after looking at these markets too. So,
yeah.
Well, guys, while you're talking about measuring blood pressure, I understand that there's some controversy regarding the ideal or target blood pressure. What number you want to stay below or at when you're looking at that blood pressure monitor? And the number in question, 130/80. And I wanted to understand why is this number controversial? Is lower necessarily better? What are some of the different arguments for this number versus 140/90, or what are the other ones that you guys are going to go over? I wanted to understand where you both landed on this issue, why this is ultimately important for clinicians. And Henry, before we get into this, as you just alluded to, I understand that hypertension is very personal for you, beyond just getting excited about video games, but it's something you've struggled with. So I wanted to know a little bit about that to kind of set the stage for your particular insights into this issue.
Yeah, I mean, before I get into it, I'm really excited to put the gloves on with Chris. He's a bit of a heavyweight in our group, so I really enjoy debating him whenever I can. But I usually walk away with a couple bruises here and there. But I will say this. So I think, the first time I had a pretty shocking revelation myself, when I think I had a blood pressure reading around 2018, when I was a pharmacy resident at the hospital. They were doing a little clinic, and I had my blood pressure read. And this is kind of going to give you, all the listeners out there, kind of like a reveal, or just kind of give you an idea of what you need to think about in terms of what impacts your blood pressure. So, I was working late, sleeping late, waking up around 5 a.m. We had morning report at 7 a.m. in some small little room for GME, or graduate medical education. So I was taking about 200 milligrams of caffeine tablets twice a day. I know some of you guys might be cringing out there, or some people might just be like, yeah, did that, been there, done that. Yeah. I worked 12 days on, 2 days off. That was great, amazing. Worked probably around 12 hours a day. And I will tell you right now, if I think about it, and I've calculated it too, because it just bothered me a lot, I was ingesting somewhere around 7 to 10 grams of sodium per day. Now, the recommended amount, or usually at least the recommended amount for those who are trying to have a heart-healthy diet, is around less than 2.4 grams a day. I mean, Chris, you can correct me on that. I know some people are starting to get a little more aggressive or a little more lax in terms of even special populations with heart failure. But it's really, really easy, Adam, to accumulate dietary sodium in that fashion. And I really want to challenge anybody out there listening to grab a box of frozen food or cheese or some of those crackers and just take a look at the sodium per serving and see just how much you're eating. And if it's reported in milligrams, go ahead and, maybe move that decimal point to the left 3 times. But basically, what you need to think about with sodium intake, and it's just a really important factor, is that water will follow wherever sodium is. And if that's within your intravascular space or within your bloodstream, then water is going to stay there and you're going to accumulate fluid there. And you're just basically going to increase the pressure of your own little environment, as in your circulatory system. So it's really important to remember that fact.
Absolutely.
And I can attest to the sodium content of stuff. Preserved food is obviously the most common culprit, but also adding salt to food. I'm very guilty of that. I love
Chris.
Yeah, I love seasoning. So, but now as a toddler dad, I pull stuff out. I try to be more conscientious of it, and like I want them to eat healthy and stuff. And I look at the sodium stuff, and I'm just like, this is crazy. But fortunately, toddlers don't eat anything, so I guess it's not really an issue. But it has been eye-opening now that I pay more attention.
Well, let's talk about the evolution of blood pressure guidelines, the ideal numbers. And Chris, take us through that history, and Henry, jump in and out of the conversation as need be.
I do want to jump in real quick because I want to tell you real fast. As a young guy, maybe 24, 25, up to even when I was around maybe 27, 28, my blood pressure was around 170 over 110 and down to even as low as, but as high as 150s over 100 systolic and diastolic. So there's anyone listening and hears those numbers as a young fella who's ingesting a bunch of caffeine, sodium, not so great physical activity, somewhat sedentary lifestyle, because I was cashed out after a day of work. Those blood pressure readings is not normal for a guy that age. So
it's good to bring awareness to a younger population. So
yes,
it's very good.
Yeah, it'd be easy to look at this as an older person's problem, but certainly not.
Yeah, absolutely. So, so like let's just go through. Let's just take it from the top, and then we'll go from there. Okay. So since 1977, not to go too far back, but to understand what we're looking at here, it's important to kind of see where we came from. So since 1997, there was essentially one main blood pressure guideline in the United States, and that was the Joint National Committee, or JNC, of the National Heart, Lung, and Blood Institute, or NHLBI. And of course, recommendations would change from one iteration to the other as new evidence became available, which of course is the norm and what you want to see in medicine. So for example, in 2003, the JNC7 recommended a blood pressure goal of less than 140 over 90. Then in 2013, we had a bit of a parting of ways. So the NHLBI actually transferred responsibility of the future hypertension guidelines to the American College of Cardiology and the American Heart Association. However, these weren't done yet. So NHLBI did release one final work in 2014, that being the JNC8, which was kind of surprisingly a bit more lenient. They recommended a goal of less than 140 over 90 for individuals under 60 years of age, and a goal of less than 150 over 90 for individuals 60 years and older. And this is somewhat of a theme that we see with other guidelines too. If they do parse things out, it's typically a more strict goal for younger, a little bit looser goal for older individuals, but those numbers were kind of staggering to some individuals in the field. But then we fast forward to 2017, and this was the most notable one that we'll be, kind of referencing today. This was the first publishing of the ACC-AHA's hypertension guideline, in which they set a more intensive goal of 130 over 80.
So if I'm understanding this correctly, Chris, that this is the number at which, if you go above, that's when a hypertension diagnosis is given. Am I understanding that right?
Correct. By this guideline standard, yes.
Okay.
So it was actually at this point, interestingly enough, that we started to...
Chris,
yeah.
Can I...
Go ahead. Of course.
I just add one thing? Yeah, I'm sorry to interrupt you. It was also at this exact point, and I think around the same time, ACP and AAFP released a guideline in conjunction where they made recommendations about individuals greater than or equal to 60 years, where systolic blood pressure the goal was less than 150. And then just a lot of other things where intensification was recommended for those with a history of stroke, high cardiovascular risk, or those people were less than 140. But I just want to make a point. It feels jumbled, right? And that's just kind of it's where a lot of disagreements can occur when things get a little nebulous. So sorry to interrupt, but you keep going.
No, and you actually make the point. It's that at this point, this is where we started to see like a very large divergence among different societies with regard to their hypertension goals and guidelines, and that's true both inside, within, and outside of the United States. We see that as well.
And I just want to say, I mean, when I was in pharmacy school and I think we were around the same age when we were in pharmacy school. But I personally, I didn't enjoy the hypertension lecture so much because A, it was really long. I believe it was 3 or 4 hours. And B, I had to learn so many acronyms and corresponding blood pressure goals. It made me want to pull my hair out. And to support my previous point, I honestly wonder how primary care physicians and other relevant specialists felt about all of these changing blood pressure goals. So like, who was or is right? And some of these guys had some good thoughts by breaking up recommendations more specifically by age and comorbidity. But yeah, sorry, I'll let you go on. I know you have.
No, that's a good preface to this, because like there are notable other guidelines out there that are reputable and people do employ in their practice. Like, you know, for example, there was an International Society of Hypertension guideline basically said like the essential goal is less than 140/90. It would be great if you could get to less than 130/80. You have the American Academy of Family Physicians. This is what is more employed, I would say, in the community in a from like a general perspective. And that's typically going to be less than 140/90 for all patients. You could consider a slightly lower goal of 135/85 to reduce the risk of heart attack. And then over in Europe, the European Society of Hypertension, they kind of stratify it where if you're less than 65, you aim for less than 130/80, and then that goal gets kind of loosened with each progressing age demographic. But then actually what was interesting to me is that the most recent guideline out of all hypertension guidelines, so the most recent hypertension guideline to come out just in general is from the European Society of Cardiology, and that was late last year, where they finally came on board with what we see with the ACC-AHA, and they actually recommend a goal of less than 130/80 for all patients. So maybe we're coming back around to some bit of unification. I don't know.
Yeah, and I just want to say, I mean, I'm going to slip in a couple more there because, I mean, 2014 ASH-ish had other blood pressure guidances, and then it's just like, I'm sure everyone is just kind of hearing ASH-ish, ESC, JNC7A, ACE. It's just, let me throw another one for you. 2021 KDIGO came out, and they kind of really shook the floor when they recommended their blood pressure management or in terms of their blood pressure goals. So they stated that less than 120 millimeters mercury systolic was most optimal relative to a large meta-analysis that was performed studying major cardiovascular event reductions in patients who achieved more intensive blood pressure goals. So they basically broke these up into 4 systolic blood pressure groups. They pitted each group against each other in a descending fashion. So the 150s over 154s, how did they do against the 140s over 144s, the 130 over 134s, and then finally the 120 over 124. And what they saw is increasingly lower blood pressure targets that are seeming to have more benefit in critical outcomes reductions. And the big thing I just want to state, and I know you're going to allude to this because I know you are personally a very well-rounded pharmacist in terms of, is the number truly the best outcome, or do we think about the patient as a whole? And the big controversy between the 2021 KDIGO hypertension guideline was, how the heck are we going to get less than 120 systolic blood pressure for some of these people who are already having blood pressure support issues? Maybe they're having some variances in their volume status as well. And basically, I just think, don't ever deal in absolutes, right? So what KDIGO basically said is that even though they were being very controversial, they were able to come out of the gate and say, we do not highly recommend, we do not have a very strong verbiage for this recommendation. That is why almost universally they state, we suggest. And that's a key word whenever you're navigating through these guidelines, everyone. It's just like, whenever you see the verbiage of these guidelines, make sure you look at the level of evidence and the grading of evidence, and specifically looking at something strongly recommend versus weakly, or even stating something as weak as suggesting that a blood pressure goal of something that controversial is going to be good for that specific patient population.
Yeah, the wording is very deliberate in those guidelines. So I think you bring up a good point to kind of like be conscious of the verbiage, what they're using there. But yeah, I'm really glad that you added another one because it all makes it sound a little ridiculous with regard to like everyone has their own number and everyone has their own guideline. Yeah. And it really all, I mean, it's crazy. And it really all kind of like begs the question, you know, is lower truly better?
And, you know, coming into today's chat and listening to the exchange you just had, I mean, my own, as the non-pharmacist in the group here, my own conventional layperson wisdom, or I guess lack thereof, was that anything above 120/80 is high. So it's interesting just to see all the disputed numbers that you guys are mentioning here.
Right. And just kind of like, you know, to your point, as an individual without hypertension, any number over 120/80 would be considered elevated. I think the issue comes into play that, okay, once the genie's out of the bottle, right? Once you already have hypertension, then is it truly necessary to get back down to less than 120/80, or is it still mitigating damage enough to simply get you down to somewhere around 130/80 or 140/90? Since you've already, you know, since hypertension has already been developed. But clearly, you know, the answer to that question depends on who you ask. So that being said, the ACC-AHA guideline, so that being the one that we're kind of referring to the majority of the time here, they actually came to their more intensive goal based on their internal review of 15 key clinical trials. And one of them was the SPRINT trial, which is a landmark trial published in 2015 that essentially provided strong evidence for lower blood pressure goals. Now, of course, this trial is not without controversy, however, but we're going to have a little bit more on that in a bit. But essentially, what the ACC-AHA's review found is that more intensive blood pressure lowering reduced the risk of major adverse cardiovascular events, or MACE, by 19%, as well as lowered rates of myocardial infarction, stroke, and heart failure. The important thing to note is that these results actually held across other populations, like those with diabetes, chronic kidney disease, as well as the elderly. Now, interestingly, to add a little bit more support is, there have been other meta-analyses performed after this that have also came to the same conclusion, essentially that more intensive blood pressure lowering is better. Even meta-analyses that excluded the controversial SPRINT trial came to this conclusion. So I think that is kind of important to note there. But drawing from these results, studies have actually looked at the potential population impact of a blood pressure goal of 130/80. So like, what's the overall benefit in a patient population if we were to implement this across every individual with hypertension? And one study compared the JNC8 goals, which, remember, those were essentially looser, so less than 140/90 for younger than 60, less than 150/90 if they're older than 60. And they compared those less strict goals to the more strict ACC-AHA goal. And they predicted that among individuals 40 years and older, that the more intensive goal would result in fewer cardiovascular events and deaths per year. This came out to 340,000 fewer cardiovascular events and 157,000 fewer deaths per year, which is obviously pretty substantial. And there was actually a second study which compared the ACC-AHA goals to what they considered standard care, as well as the JNC7 goals and the JNC8 goals. And they ended up predicting that among individuals 45 years and older, that the more intensive ACC-AHA goal would result in fewer cardiovascular events over 10 years. Those numbers were 3.8 million, 2.6 million, and 1.6 million, respectively, with 3 million fewer being attributed to the more strict goal, obviously.
Nice. I mean, before you go on, I just want to mention, I mean, when you look at all of these studies and the inclusion criteria, or what the patient typically looked like in these landmark clinical trials, I find it very interesting that none of these age groups include people like you and me, Chris, or even Adam. And I think we do need to have an understanding of, we need representation for those who, number one, eat too much salt, maybe drink a little too much alcohol and ingest too much caffeine, as well as other lifestyle issues that may arise. And us young bucks, we're out there hustling. And I'll give you an anecdotal case. I mean, I do have 2 friends from pharmacy school who did experience a heart attack. Can't really say exactly what must have happened, but I know that a lot of us in that phase of our lives were doing exactly what we're doing. I knew a guy who took a caffeine tablet, 200 milligrams, 3 times a day. And he chased that down with a Red Bull. And it really makes me cringe thinking about it. But luckily, we had a study called the Carter study come out. And that's the coronary artery risk development in young adults, where there were 3,851 young adults followed over about an 19-year period with only about 4% taking antihypertensive agents. The primary outcome was the adjusted hazard ratio for cardiovascular disease events by group. And this study, interestingly enough, adopted ACC-AHA staging for pre-hypertension, stage 1 and stage 2. So, within the realm of 120 to 139, 140 to 159, and greater than or equal to 160 systolic blood pressure, respectively. So those with elevated blood pressure above 120/80, that first group had an adjusted hazard ratio of 1.67. So about 67% higher chance for that primary outcome. And confidence interval was up to 2.77, did not dip below 1. Stage 1, those individuals, their adjusted hazard ratio was 1.75. And stage 2 folks, for that primary outcome of cardiovascular disease events, was a staggering 3.49, up to an upper end of the confidence interval of 5.05. So just to mention, with the concerning rise of obesity in younger adults, children, higher prevalence of type 2 diabetes and hypertension, and isolated hypertension in younger patients, and that isolated hypertension could be that that phase in your life or something along those lines, that is still associated with the high lifetime ASCVD risk. And it may be time for people our age and for us to highlight the benefits of lifestyle modifications as, and other means of reducing sodium intake if possible, just to highlight the benefits of what is already out there for at least non-pharmacologic therapy if your clinician or your provider, as well as yourself, are not ready to be within a 28-year age group or low 30-year-old age group to be on an antihypertensive.
Yeah. I think that's, I think I mentioned it before, but with one of your other anecdotes, I mean, it's good to raise awareness for the younger population, because I don't think it's really addressed. It's not addressed in clinical trials too much, but it's certainly not really addressed in the clinic setting either, unless it's overt stage 2 hypertension. I don't think a lot of people like to approach a younger individual and suggest putting them on a hypertension medication. But no, I think it's something to address. And thanks for putting me in the young buck category as I rapidly approach my later 30s. So
30s I like is the new 20s, right?
Yeah, right.
Yeah. Thank you, Henry, for that as well.
So, kind of harkening back to all of the, the data that you had mentioned in the Carter study and those population-based, event reduction studies, like the data is compelling. Obviously. However, it's important to highlight that the majority of the trials that went into the ACC-AHA's review, as well as those subsequent population impact studies, a lot of these were quote unquote treat to target trials. And while this may seem like a minor point, the main critique of treat to target trials is their tendency toward performance bias, where essentially the more intensive group inherently gets more attention from investigators, since more intensive treatment requires more frequent, typically 20 to 30% more in-office visits. And just by the nature of the participants being in the office more and having more attention put on them, this can result in unblinding in the intensive group, because they kind of understand hey, I'm being actively monitored way more frequently than I probably should. So I must be in the actual treatment group. And this may cause them to potentially be more adherent, since they know they're being more closely monitored, and they're possibly even more diligent from a lifestyle modification perspective.
Bad for research, but good for those patients overall.
Yeah, absolutely. And I think it really says something about the dangers, not necessarily the dangers, but the caveat of comparing a very intensive clinical trial to real world experiences, because they're not always going to, and as I'm going to mention here, shortly, they're not always going to line up well. Like the real world is not perfect. It's not a perfect clinical setting like you see in a clinical trial, and that can be good and bad. So, and I'll bring up a point here shortly. Another concern is that much of the evidence supporting intensive therapy is derived primarily from patients with either established cardiovascular disease or those with an increased risk for cardiovascular disease. And it may not always be appropriate to extrapolate the benefits of this strategy to those without cardiovascular disease and who are at a low risk for developing cardiovascular disease. So for reference, of all the individuals in the SPRINT trial, that, somewhat controversial, more intensive is better clinical trial, 76.5% either had established cardiovascular disease or were at an increased risk of cardiovascular disease. And notably, the SPRINT trial was one of the trials that played an outsized role in the establishment of the ACC/AHA's recommendations. Now, because the SPRINT trial was so influential in this recommendation, it's important to discuss some of the common critiques surrounding it. Well, essentially, SPRINT asked, which is better, a systolic blood pressure of less than 120 or less than 140? And one of the biggest criticisms is the way in which blood pressure was measured by using an automated blood pressure cuff without anyone in the room, meaning that the individual was completely unattended. Now, it is important to note that while many real-world practices are now adopting automated cuffs, that's certainly not true of every single practice setting. And it has been noted in yes. Yeah.
Sorry, I do want to interject one point, and it's something I do feel strongly about.
Yeah.
I have a slide in one of the recent webinars that I did for hypertension that really, I don't know if it goes against the grain, but as a pharmacist, I do think it's important to highlight any objective knowledge, collection, or anything like vital sign, and what is the guideline recommended way to collect it. And it's just to your point. I mean, how often do you guys, when you go into the office, how often do you feel like it's a very calm process? Yeah, everything is all nice and bright and white, or calm candles burning or something? Or how often does it seem like you're on the trading floor of Wall Street and there's bells ringing everywhere around you? Mm-hmm. And it just brings me to a point that whenever you have your blood pressure read, it is important that either you mentally are aware of this, or if at least your office is pretty good about getting you in and taking your blood pressure in a very calm manner. There is a list, and it is detailed per a couple studies. So the patient needs to be rested for at least 5 minutes. They need to be seated with back support. Their feet are flat. The arm is supported at the heart level. The correct cuff size is used, and that is very often overlooked. Multiple readings are taken. Your averages can be calculated. Proper technique, no talking, and making sure that there really wasn't any recent stimulant use. And I personally, I have my blood pressure monitor right next to me. And there are times when I see the blood pressure that I have, and I get a little scared, but then I'm like, wait, I just had a cup of coffee. Wait, I just walked the dog and I just rushed back in. So just to keep everyone in mind, the way you take it, that's one thing, but the overall mood and the overall approach, it needs to be done in a fairly calm but regimented manner.
Yeah. And I can tell you from my experience, I routinely go to my rheumatologist's office, and they're great with, like, there's never any wait. Like, I get there and they're really quick at getting me back into the room, and I'm always late getting there. So I get out of my car, I like speed walk like 100 yards to get from the parking lot. And then I get in there and they're like, come on right back. And then I sit in the chair and they're like, we're going to take your blood pressure. And I'm thinking, this is going to be elevated. So it kind of harkened, and they're fantastic, but at the same time, it's a very common, they don't commonly do the quote unquote guideline recommended blood pressure blood pressure measurement technique, like you mentioned. But it's very important to at least be mindful of when we can. But kind of harkening back to the issue with automated cuffs is not an issue per se, because I like automated cuffs, but it's been noted that in clinical trials that automated cuffs typically produce blood pressures lower than when performed by the traditional method. And additionally, it's also been documented that blood pressure is slightly higher when a healthcare professional is present. So by its methodology at heart, blood pressures in the SPRINT trial were lower than what would be seen in potentially be seen in an equivalent real world setting, meaning that if an individual in the trial, say, had a systolic blood pressure of 125, that may equate to a systolic blood pressure of 130 to 135 in the real world. So you might be asking yourself, like, why is this important? Well, because in a setting analogous to SPRINT, where everything is perfect, that patient may be deemed at goal by the ACC/AHA standards and no further medication would be needed. However, that same patient in the real world would be deemed not at goal and then could potentially be given another medication.
I find this interesting because, in a research setting, you usually want to remove that human influence on the data collection. But certainly, I can see the appeal of having the automated blood pressure cuff for this, but, comes with the problems that you just outlined there. Yeah.
And that's why, I like automated blood pressure cuffs. I don't want to be on the record as saying that I don't like them. It's just that disconnect between the pristine clinical setting as opposed to the quote unquote real world setting, essentially. Right. And, we kind of have to think about this because in this hypothetical example, we would potentially be giving another medication, and the addition of another antihypertensive medication is certainly not trivial. When we look at the SPRINT trial, those in the intensive goal required an average of 3 medications versus only 2 for those in the less intensive goal. This extra medication was accompanied by a marked increase in the incidence of side effects, such as hypotension, syncope, and electrolyte abnormalities, which certainly should not be overlooked.
Yeah, exactly. I do want to mention, is it the blood pressure goal that we're chasing, or should we also be thinking about the patient-specific factors that are influencing their activities of daily living, as well as what's happening internally in terms of the mechanism of these drugs? And a lot of times the mechanism of action of these drugs or the pharmacology is going to impact what you stated, specifically electrolyte abnormalities. And something I always like to think about was a meta-analysis performed by Yang and Associates in 2018, where they assessed the impacts of something like spironolactone's uptake and use for CKDers, as well as another meta-analysis performed by Sikora and Associates of 2021. We need to remember that we cannot just chase the numbers to feel good. So basically, what I took away from this study is, from a population health perspective, when new drugs come out and they're recommended, there are things that we need to look at, whether it's the adverse reactions, adverse effects, or electrolyte abnormalities that occur. And what happened basically from these 2 meta-analyses was that there were increases in hyperkalemia relative to spironolactone usage. It's very notorious. Its mechanism of action plays on that electrolytes retention. So there were increases in hyperkalemia-related hospital admissions, as well as hyperkalemia plus acute kidney injury whenever spironolactone was beginning to be employed in mass, respectively. So just another point I like to bring up is just, chasing just a number, yeah, that's great, but there are other relative factors that will maybe send your patient back to the hospital or potentially cause harm if not monitored closely.
Right, because you have to kind of look at the whole patient. It's not like you're just treating like a computer program or something like that. It's a patient as a whole, right? So when we think about the adverse effects, in more severe circumstances, think about syncope. That could lead to falls in the elderly, which could then result in a fracture. And that certainly comes with its own serious cascade of events. However, to play devil's advocate, the point could be argued that, well, in the general population, that's a rare event. However, it's important to remember that in the real world, when an individual experiences an adverse event with a given medication, no matter how serious it may or may not be, they can often be hesitant to restart it or even try another agent in that same drug class. So we've effectively eliminated a treatment option moving forward should we need it in the future. Additionally, this may create an aversion toward having their blood pressure go too low. So by trying to treat the patient too hard, we may actually inadvertently dampen a patient's desire to treat their blood pressure at all. And thus this whole process becomes somewhat counterproductive.
Just a very quick diversion here, but when you're having a situation like this, what can be said for the non-pharmacologic interventions?
I feel like Henry would be a good person to talk about this, huh?
I mean, yeah, I would say, whatever your doctor recommends in terms of what activity level you are able to or qualified to perform, what your doctor also recommends in terms of whatever dietary sodium intake is most optimal for you. Usually, I personally like to pursue less than 3 grams or less than 2.4 grams per day. You still need salt. Don't forget that. That is what is also going to support your blood pressure to be. And that's a big thing, hypertension is bad. Hypotension is just as bad because you can have people who are falling because they're experiencing dizziness or orthostatic hypotension. But remember, a really extreme case that you can extrapolate this from is whenever you have people presenting for septic shock, right? Septic shock can have blood pressures as low as 60/40 or equating to a mean arterial pressure like less than 65. And what that basically means is you reduce global perfusion within your body, and you are not going to be able to perfuse oxygenated blood through your kidneys, through your liver, to your extremities. So don't forget, everyone. I mean, sodium, don't completely cut it out. Talk to your doctor about it and everything like that. But it's absolutely needed for good global perfusion. But also what you can do is you can have a heart-healthy type of diet. You can adapt the DASH diet. You could pursue 150 minutes of exercise broken up 5 days a week for like 30 minutes a day. And just remembering that your heart rate must be above resting rate to be cardio or cardiovascular exercise. And I think a lot of listeners who may not be so familiar with heart health and blood pressure, I do want to remind too, there's a reason why we always bring the heart back into the equation. The circulatory system, when it is too high of a pressure system, the return blood flow back into your heart causes something where it increases preload. You're just shooting blood pressure into the chamber of the heart. And then the other side of it is if you have high blood pressure that's pushing against what your heart is trying to push out, your heart has to do a lot of work just to get that blood out of the chambers into your extremities. And what that could potentially cause is some issues with heart damage. But overall, yes, Chris, like exercise, dietary intake changes, not having such a sedentary lifestyle, and really pursuing the dietary recommendations that your doctor recommends, such as lesser sodium intake or more optimal intake of potassium salts even. So there's that.
Yeah, absolutely. That's what I was thinking too. It's going to be higher intake of potassium, lower intake of sodium, and then your general DASH or Mediterranean diet, which is going to be higher in fruits and vegetables, less in terms of red meats and fats and sodium, like you had said. So it's just a general a general all-encompassing type of lifestyle. Moderate alcohol intake and caffeine intake and whatnot as well. So there's a lot of different ways that you can do that. But again, always in conjunction with your provider to make sure that your level of physical ability corresponds to your desired level of physical activity as well. So, cycling back, I want to take a minute and cycle back to another important critique of the SPRINT trial. is that it was kind of weird in that it made a binary comparison between two groups of patients with actually a widely different blood pressure target. So if you remember, they were comparing a blood pressure target of less than 120 and less than 140. So having such a wide gap between targets kind of makes it uncertain whether the benefits of blood pressure lowering continued to improve as blood pressure went toward 120, or if there was like a certain threshold, like less than 135, less than 130, less than 125, beyond which no further benefit could be obtained. So I think having like a sliding scale could have potentially helped to some degree to delineate that. But to these points, a meta-analysis that excluded treat to target trials, again, to eliminate that performance bias, essentially showed no cardiovascular benefit to lowering systolic blood pressure in the 130/140 range in the primary prevention cohort. So those being individuals without established cardiovascular disease. Now, in the secondary prevention cohort, so those with established cardiovascular disease, lowering systolic blood pressure in the 130/140 range actually did result in a 9% reduction in all-cause mortality and a 15% reduction in major adverse cardiac events. However, adverse events leading to discontinuation were doubled. So again, the benefit to risk ratio in this instance was balanced. So like we mentioned before, you kind of always have to compare the risk of adding an additional agent to the risk of, or the benefit of adding an additional agent to the risk of any potential adverse effects it can cause. So in all, a lack of consensus across guidelines can be frustrating. But what I think it really says is that, as with all medicine, it really requires an understanding of patient-specific factors and clinical judgment. That being said, for a general answer, I tend to land somewhere in the middle of the pack with regard to blood pressure treatment goals, both from an efficacy and a practicality perspective. I do believe that a lower blood pressure goal of less than 130/80 is better, particularly if a patient has high risk for cardiovascular disease or if they have established cardiovascular disease. However, I also believe that a lesser goal of less than 140/90 is also reasonable for lower risk patients without cardiovascular disease, particularly elderly patients or those who simply cannot tolerate a more aggressive goal.
And to put a bow on this entire discussion, I guess we got to find out, Henry, where do you fall? Are you also a middle of the pack practitioner this way?
Yeah, I'll take the gloves off for this one. Just kidding. But I'm in the exact same boat. The evidence from clinical trials is relatively robust for less than 130/80, especially for those with cardiovascular risk or established cardiovascular disease. And also what we know is we have population health impacts and possible consequences of kind of easing those blood pressure goals, as we were alluding to earlier, and especially what Chris named. And it definitely is a goal I like to pursue with my own patients that fit the demographic. And for those that are unable to manage a blood pressure goal that is aggressive or handle that more, rather of a better word, the overall number two is I would probably pursue something of less than 140/90, especially when you're starting to combine these pharmacotherapeutic agents with those of higher age or even the geriatric realm. So my hat's off to you, Chris. You always are pretty established in your opinions, but I'm also pretty established in your corner of the ring too, man. So yeah, thanks for that.
Good. Thanks for helping fill in the conversation as well. There's a lot of different information out there, and it's crazy to try to put it all together. So it's nice to put our heads together and kind of come up with a general consensus.
Yeah, and I just want to say one thing. I just took my blood pressure, and it is 118/78. So I didn't stress out too hard. I did it while I was listening to this whole thing. And I do want to remind everyone one more time, there is a dot that is located on the blood pressure cuff that you need to align it with your brachial artery. And that brachial artery is what is listened for by whomever provider that you're dealing with. And they're basically listening for the appearance and the disappearance of that sound. So that's why you guys got to make sure, if you're using your cuffs, make sure you align that little dot or that little target that they create with the brachial artery located slightly above your elbow, inner left elbow, inner right elbow, right in this little spot that if you feel for it, you can feel even like a little pulse there too.
Good PSA.
Yeah, absolutely. And thank you guys. That was a wonderful, wide-ranging discussion.
In the realm of corrections health, not all electronic health records are created equally. Sapphire EHR is a comprehensive, cloud-based electronic health record designed specifically for correctional health providers. Since 2011, Sapphire has worked one-on-one with healthcare staff in jails and prisons to develop and refine a suite of features and modules to manage total inmate patient care. From MedPass to dental care to documentation of lab results and creating custom forms, Sapphire's correction-specific features can be scaled to meet the needs of the largest correctional facilities down to the smallest local jails. And it's all backed up by 100% in-house hosting, training, and support, with a 24/7 help desk. Get a closer look at the Corrections EHR deployed in over 400 facilities across 36 states and territories. Visit www.sapphire-health.com and schedule a demo today. Sapphire EHR, cloud-based, compatible, correction-specific electronic health records. Now back to PodcastRx with Chris Bender.
All right, so I had mentioned earlier that this was originally a February episode, this entire topic, and we're now bringing it back for April. But in a way, it's kind of fitting that I did that because there is actually an anniversary of the passing of a major historical figure 80 years ago that actually had a lot to do with hypertension awareness. So, Chris, lay some history on us here.
Yeah, absolutely. So nowadays, hypertension and its treatment is so ubiquitous that most everyone is aware of it. But did you know that this wasn't always the case? Now, of course, as with most of our trivia, there is evidence to suggest an awareness of hypertension even back in ancient times. Chinese medical texts from 2600 BCE describe how excess salt can quote-unquote harden the pulse. And Egyptian texts from 1500 BCE describe an association between this palpable pulse and the development of heart and brain afflictions. However, it wasn't until the late 1800s with the development of the sphygmomanometer, otherwise known as the blood pressure cuff, that hypertension was recognized as a clinical entity. Now, this recognition, however, did not immediately lead to an uptake in treatment, with some even arguing that hypertension could be an important compensatory mechanism in the body. No, it wasn't until the death of President Franklin D. Roosevelt during his fourth term in office, as Adam alluded 80 years ago this month, that the impacts of untreated hypertension gained public attention. FDR was diagnosed with hypertension at age 54, but didn't receive treatment for another 4 years when he was ultimately prescribed phenobarbital and massage therapy for a blood pressure of 188 over 105 in 1941. What? Yeah. Now, unfortunately, as time went on, his blood pressure and, of course, his overall health continued to worsen until eventually, after a recorded blood pressure of 300 over 190 on the morning of April 12th, 1945, FDR died of a hemorrhagic stroke while he was sitting for a portrait. Now, FDR's death highlighted the lack of safe and effective therapeutic options for hypertension. Now, fortunately, as the practice of hypertension management grew, so too did the treatment armamentarium. After World War II, hexamethonium, hydralazine, and reserpine were used. However, the biggest breakthrough was the introduction of the diuretic chlorothiazide, that being the precursor to our modern hydrochlorothiazide, which was well tolerated and clearly prolonged the life in hypertensive patients. From there, progress was steady with the introduction of the first beta blocker, propranolol, in 1967, the calcium channel blocker, verapamil, in 1981, the ACE inhibitor, captopril, in 1981 as well, and the angiotensin receptor blocker, losartan, in 1995. While newer, more potent agents in these classes have since been introduced, these classes of drugs, minus perhaps the beta blockers, form the cornerstone of hypertension management as we know it today.
Wow.
You know, I I had no idea that FDR's death was the bellwether of modern hypertension management. But looking at that, anyone serving 4 consecutive terms as president amidst the Great Depression and World War II is going to have high blood pressure on the very best.
I know. And go ahead, Henry.
No, I mean, no offense, but you're blowing my mind. I mean, I did not know that. And I usually followed you. I thought I did U.S. history thought I did pretty well in that class, but I did not know that.
I didn't either, actually, admittedly. I thought that was, and the numbers that his blood pressure readings were astounding, especially that last one on that fateful day. It just really, this was all old-timey medicine in a nutshell, but the phenobarbital and massage therapy was great for blood pressure. It just was like, it just really highlighted, like, okay, we don't have anything for this, so let's just relax you, essentially.
Well, I do want to say, I mean, just to make a point, I mean, I don't know how he felt, but imagine all the people walking around with blood pressures maybe in that realm who don't even feel it, or maybe has like a light headache, or maybe their vision is blurry all the time. But it just kind of like reinforces to me, like, hypertension can be truly a silent killer. And it's like, I challenge everyone just if you see that blood pressure machine at your local grocery store, if you see it laying on your desk next to you, don't be afraid to gain the information to give you the motive to act. Because if you have the information there and available, especially because we have blood pressure monitoring in every grocery store, or you can buy a cheap $20 automated cuff at whatever big box store, it's all there for you. So it's up to you to make the decision. Hey, it's elevated. Do I want to undergo this silent process that may end up in this or that situation? So that blows my mind, Chris. Thanks for that.
Yeah. Well, you know what they say, knowledge is power, right?
Oh yeah.
A lot of great pharmacy nerdery there in that one as well. I knew you guys would chew on that for a bit. Well, gentlemen, we're running a bit over time here. So again, thank you so much for getting together today and keeping the conversation light, so much so that Henry had a really positive blood pressure reading. So, and Henry, pleasure to have you back on the pod. Please come back again soon if you can.
Yeah, as long as you invite me.
Absolutely. We definitely will be getting you back on here. This was a lot of fun. As the show facilitator, I really enjoyed just sitting back, listening to you two talk shop, and no doubt the listeners will as well.
Hopefully everyone got a lot out of it. It was a pleasure doing it. Henry, thanks for joining me, man. This was awesome.
Hey, thanks for having me, guys. I had a lot of fun.
Oh, you're so welcome, and we'll definitely be getting you back on. And just a quick bit of housekeeping. If you enjoy the PodcastRx program, please make sure that you're following us where you listen to your podcasts. And if possible, leave us a rating or review. And as usual, full show notes with references to the material discussed in today's episode will be available at diamondpharmacy.com/resources/blog. All right, fellas, we're just a couple days away from Easter as we record this, so I'll end things by wishing you both a very happy holiday weekend coming up and time well spent with your families. Thanks again for being here.
Hey, likewise. Take care.
You too.
All right. PodcastRx features conversations with healthcare professionals. The statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as the substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein.
PodcastRx is a production of Diamond Pharmacy Services. Find our show on Apple Podcasts, Spotify, YouTube, or wherever you enjoy podcasts. And where possible, please rate and review. If you'd like to get in touch with the show directly, shoot us an email at podcastrx@diamondpharmacy.com. Thank you again for your support.